see this diagram. So maybe you can mention what you can see on the gross morphology. Yes, so someone says multifaceted stones, yes, yellow stones, I agree. Yellow pebbles like appearances, yes, I agree as well. Yellow stones, Distended gallbladder, yes. So maybe if you don't know it's a gallbladder, you can say a distended pouch-like organ, right? Looks like a pouch, right? And inside it, you can see several pebbles, which are sort of yellowish. Some are also sort of brownish, blackish in appearance, right? But the predominant color is yellow. And those stones, how do they look? They are multifaceted. They have many corners, many edges, right? So what do we suppose these yellow stones inside a pouch could be? Because someone has already told us this is a gallbladder, right? So that's a distended gallbladder. So maybe what do we think these stones could be? Cholesterol stones. Someone says mafuta ya nini? Cholesterol stones. Cholesterol stones, I agree. Okay, so what are some of the characteristics of cholesterol stones? Maybe someone mentioned about a characteristic regards to radiology. Another person has already mentioned their characteristic that they are multifaceted. So on radiology, will they appear? Exactly. So they will appear radiolucent on radiology or radio imaging. Now, where do they arise exclusively? They arise exclusively in the gallbladder. So those are the characteristics. What are some of the risk factors associated with gallbladder? Sorry, not gallbladder, but cholesterol stones. Estrogen, I agree. Being female does because of the hormones that they produce, including estrogen. Let me read the responses. Fatty food, which can lead to hyperlipidemia, obesity, yes, stasis, which is prolonged periods of inactivity, such as example, bed rest. So I think I'll maybe probably agree with that as well. Fertile female in her 40s. So maybe the female gender. Oral contraceptives, yes. This I think can either cause stasis or hypercoagulability, which is okay. Cirrhosis, not very sure. Maybe we can confirm that. Dehydration as well, maybe we can confirm that. But dehydration, we know could probably cause kidney stones. That's what is more common for dehydration. For gallstones, maybe we confirm that. Multiparity. Is multiparity an exacerbating factor or an elevating factor? Maybe someone can confirm that. Drug clofibrate, sure about that, but maybe the person presenting can present the answers that we came up with. So we had advanced age. So when you're older age, you're predisposed to formation of gallstones. When you're female in gender, so if your sex is female, then you're predisposed to gallstones because you have hormones such as estrogen, which might lead you to get gallstones. You have use of oral contraceptives, which some are reconstituted of hormones like estrogen. Also, you have pregnancy. So the person who mentioned multiparity was on the right track and was correct, I suppose. And then you have obesity, hyperlipidemia. Someone mentioned about was it eating too much or something? Family history, I agree. And then you have weight reduction. Maybe rapid weight reduction. So those are the causes of, or the risk factors of gallstones, and specifically cholesterol stones. Okay, let's move to the next picture and describe its pathology. Why rapid weight reduction? Maybe someone can tell us in the chat. Anyone in the idea in the chat? Mm-hmm. Mm-hmm. Any ideas? Okay, so I'm not really sure myself, but I think someone has put it in the chat. They say breakdown leaves triglycerides and fatty acid that aggregate. And also someone said fatty lipolysis increases cholesterol in circulation. Yes, so I think those sound like very plausible explanations, and I like to assume they're right. So we have fast lipolysis leading to increased levels of cholesterol in the circulation, right? And cholesterol is used in formation of these stones, and also breakdown of triglycerides and fatty acids that aggregate. Okay, so let's describe the morphological features of the following pathology. What do we sort of see in this picture? Black stones, yes. They're small in size, I agree. So radio opaque, maybe yes, that's a characteristic. Someone says a popo. Yeah, maybe a popo appearing like maybe instead of saying a popo, you can say a popo appearing like organ, or instead of saying a popo appearing like organ, you describe which features of a popo exactly it looks like. So maybe you can say it looks like a hole, which a cavity with small seed-like materials inside, yeah, and yellow or yellowish or orangish, or sorry, orangish. Yeah, maybe instead of saying purple, that would be better. These are multifaceted. I disagree. They're round, so they don't have facets. They're just round. Enlarged gallbladder. Maybe if you don't know what this, if it's a gallbladder, yeah, you just have to find other ways to describe it without mentioning gallbladder. Okay, great. You guys are doing extremely well. Let's move to the characteristics. So someone mentioned radiopaque. What other characteristics? Someone also mentioned small. Also, maybe I can get two more characteristics of we expect of, sorry, I even forgot to ask, what do you think the pathology could be? Someone already preempted and said crumble easily, which is true. But what do you think this pathology could be? Pigment stones, that's correct. So for pigment stones, there are many, they're small, they easily crumble to touch, or they're fragile to touch. Someone told us they're radio opaque. And one more, found in the sterile gallbladder bile. Remember we said the cholesterol stones are found exclusively in the gallbladder, but these ones can be found also in the bile. Right, so you guys are doing well. Maybe we can move to the next question. Any questions on that? No questions. So here we can see a slice or sectioning of the brain, right? But there's something peculiar about this section. There's sort of this color change. Maybe we can describe this pathology morphologically. Yes, we see yellow deposits, right? Maybe we can mention the segments of the lobes where they are found. So mostly in the basal ganglia, right? Will I be right to say basal ganglia? And also parts of the temporal lobe, the lower parts of the temporal lobe. There's also a decrease in the fourth ventricle, maybe, but also it could be the part or the section of the brain that this is cut from, right? It could just be it's cut from a little bit far back, or a bit far back. So that's the only part of the ventricle, lateral ventricles you can see. Or what someone said, fourth ventricle. Gray matter is not visible. So it's mostly white. Yes, I agree with that one. Gray matter is not visible because it's been replaced by this yellowish material. Right, so what do we think this pathology could be? What could this pathology be? Yes, Kernicterus. Kernicterus, that's correct. So what is sort of the pathophysiology of Kernicterus? How do we get Kernicterus? Yeah, so when we have a lot of unconjugated bilirubin, right? This bilirubin can cross the BBB and find itself into the brain, where it goes and sort of is deposited in the basal ganglia. And here, after it's deposited in the basal ganglia, you'll notice the yellow-like materials instead of the gray kind of usual appearance of the gray matter. I hope that is okay. Maybe we can move to the next question. Let's move to the next question. Okay, so in this picture we see something. Maybe people can describe the gross pathology, the gross morphological features of this. Yes, we see hemorrhage, we see a clot. Yes, those are good responses. Okay, maybe we state the pathology and why we think that could be the pathology. Yes, red areas. Someone tells us a subdural. Subdural. Why do we think it's subdural? Why do you think it's subdural? What are your responses? Okay. Any response apart from subdural? Who thinks it could be something else other than subdural? So the clot is below the dura. That's why it's subdural. So this should be epidural hematoma. So maybe we can discuss how to recognize differentiate between a subdural and an epidural hematoma. So how do the layers of dura sort of arrange themselves? Usually have sort of below the bone, directly adhered to the bone, is which layer of meninges? Directly below the bone, bound to the periosteum. It is the dura, right? And then below it, we have the arachnoid layer. So I want us to like picture in our heads the arrangement of these layers because it's very important. I've been coming up with responses of these answers, and maybe it will help you easily identify. So usually we have directly adhered very firmly to the periosteum is the dura, followed by arachnoid, right, layer. And then below that, directly adhered on the brain parenchyma is the pia mater, right? So usually we have epidural. Epidural meaning it's in between the periosteum and the dura, right? And then we have subarachnoid, meaning it's below the arachnoid, right? And then we have so below the arachnoid, right? And then we have which other thing do we have? We have epidural, subdural, and subarachnoid. So subdural means it's below the dura. Now, in order to tell the difference, here is how it works. When I have a bleed or I have a tear of the medial meningeal artery, right, at the pterion, I'll have a bleed in between the brain, or not the brain, but the bone and the dura. And because the dura is so firmly attached to the periosteum, this blood will sort of pull inside that space and form a D-like appearance. And so it won't spread out throughout the brain, because the only places that the dura usually is very attached, as I said before, to the skull, to the periosteum, to the bone, and even more firmly attached are the sutures. So what usually happens when blood leaks in between this layer, it will spread out through that area, but not that far, because it is being bound by the sutures where the dura attaches into the periosteum very firmly. Now, that's how you recognize epidural, because of not a very large area of spread. Now we go to subdural. So for subdural, it's because of the bridging veins. And now because the bridging veins are not really, because this layer is not really adherent to the bone, blood can travel over long areas. And so since blood can travel over long distances, this kind of hemorrhage usually has a large area of distribution. But this blood can wash away. Now we have subarachnoid. Subarachnoid is sort of the least, or the one below arachnoid, right? So this one, when you go to wash it away, you should not wash away with water. It's like the blood is in the brain. And that's like kind of how you tell the difference between these. So for this picture here, the area of spread is not that extensive. And so you come up with epidural hematoma. Right? Maybe we'll see more examples of this. But this is an epidural hematoma because this spread is not as extensive. Right? And above that and below that, we can see we have the dura. And then above it, you can see this is, I think, the scalp that has been retracted. And below the scalp, there's the skull, the calvarium. And now there's this epidural. And now below that, this white thing, here is the dura. So you can see it's overlying the dura. It's not below the dura. And that's why this is epidural and not subdural. Now, which artery rupturing leads to epidural hematoma? Yeah, the medial meningeal artery. Good. Okay, let's move to the next question. So here is just a point of note. Presents with initial loss of consciousness, a lucid interval between a period between regaining consciousness after a short period of loss of consciousness. So the simple mean is, usually for epidural hematoma, we've said it won't spread throughout the whole brain or throughout large areas of the brain. This is because it has been confined to this specific area. But this blood is still becoming more because this artery is leaking or is torn. This blood looks for a place to go. And so as it fills this limited space, it will sort of expand. As it expands, right, it increases the pressure, or it increases the space of the mass space that it's taking. And so usually what you have in patients presenting with this, they have lost consciousness, then they wake up after losing consciousness. This is what we call the lucid intervals. And after a short while, they think that they're fine and okay, and they go home. And then after that, they lose consciousness again. And this is usually fatal, because now the second loss of consciousness ends up being fatal, because now the space that is occupied by this pool of blood is so huge. and it can cause pressure effect on the brain and add damage to the brain. And so when you have a person losing consciousness after a traumatic brain injury, and they've lost consciousness and they wake up, do not discharge them immediately, but you do further evaluation. Even if the patient says they feel well and they want to leave, the further examination is still warranted to know if they're still bleeding in the brain. So we said thunderclap headaches are for subarachnoid. This is when you have a rupture in the berry aneurysms. Yeah, sawa sawa. We move to the next. Okay, so what do we think this could be? Is it subdural? Is it epidural? Is it subarachnoid? Dural, sub or epi? Epi, awesome. So why is it epi? Let's look at the dura. So maybe I can help. We can see the dura, that sort of blanket-like or sheet-like thing covering the brain, right? This hematoma, is it below that sheet or is it above that sheet? Is it really below? I think it's above the sheet, yes. And so if it's above this sheet covering the brain, we'll call it epidural. Yeah. I hope we can see more images of this. There is like brownish, like you see this envelope, the brown envelopes. There's this thing that looks like an envelope, and this black part or this hematoma is sitting on that envelope looking kind of thing. Now, when you look at that envelope and the position relative to which this hematoma is, it's seated on top of it, and that's why it is epidural. If it was below, that would be subdural. And also, this hematoma is sort of confined to this one place, to this sort of one area, generally speaking. And that's why we call it an epidural. What are those folds on the right? Which folds are we talking about on the right? This folds, the one that looks like a clot. That's the hematoma. That's the hematoma. Okay, let's move down. I think this is an image, a radiographic image of what we were explaining. Let's move down and try explaining with that image. So this is basically what I was explaining. Look at where those arrows are pointing. So we can see the skull, right? That whitish border going all around. And that is the periosteum. And you can see this hematoma that is sort of radiolucent, right, is indenting the brain or the brain parenchyma in a D-like fashion. Yeah? It looks like the capital letter D, sharply indenting the brain. This is because this dura is firmly adhered to the sutures or the suture lines of the periosteum. And so when blood looks for a place to go, it cannot go beyond these suture lines on either side, either up or down. So where does it logically have to, anywhere else has to go and occupy space? Inside the parenchyma. So the swelling is going towards the inside of the parenchyma, forming this D-like appearance. So this D-like appearance is very characteristic of epidural hematoma, because the dura is firmly attached to the periosteum, and therefore blood doesn't have anywhere to go other than inside, right? So blood would spread in large extensive areas inside the brain. And that's why this image above, you see this blood or this clot is sort of limited to a single, almost single area, right? I hope now you understand it better. The epidural hematoma. Is that at least better understood now? Okay, we move to the next question, the next image. Yeah, awesome. So for this, what do we think this could be? Now, look at that sort of glossy envelope-like sheet. It has now been retracted. So this clot, is it below the sheet or above the sheet? Yes, someone says it's subdural, yeah? And maybe we can try to come to that conclusion with everybody else. Let's try to get everybody on the same boat. This reflected sheet, right? Is this clot below the sheet or above the sheet? It's below, exactly. So we'll call this subdural. How is the extent of the spread? Is it centered in one area or is it sort of spread throughout the brain? Yeah, it's spread because there's nothing binding the spread of this. What happens is the bridging veins are destroyed or ruptured, and therefore, since this area of the brain or this dura is not firmly attached to the skull, blood can freely just spread throughout the brain. And so you see it has this sort of large and expansive areas of spread. And this is very characteristic of subdural hematoma. Yeah? Now you've seen the difference and you can clearly tell, right? Maybe you look at where the dura is and you tell if it's sitting above or below. And if you can't clearly tell, maybe the spread will help you. If it looks like sort of confined with good edges and good borders, that's most probably epidural. If it looks sort of spread and below the dura, that is subdural. Is that better now? Yeah. Now, what is the cause of subdural hematomas? What usually leads to subdural hematomas? Which structures, when they rupture, lead to subdural hematoma? I think we've said it, the bridging veins. Yeah. So they connect, yeah, exactly. They connect the cerebral venous sinuses to the superficial vein of the skull, rupture due to trauma. And also, especially for the old people, for example, people who have Alzheimer's, when the brain is atrophying, so these vessels are kind of pulled out from each other and they become thinner. So when old people fall, they're at high risk of subdural hematoma because now their bridging veins are sort of pulled against each other. There's a lot of tension because of the atrophy of the brain, and therefore they are very susceptible to this kind of bleeding. So blood accumulates between the dura mater and arachnoid layer. Great. Let's move to the next one. Maybe this will clarify more on this. Now here we can't clearly tell where the dura is, but one thing we know, it's very well attached to the periosteum, right? And so even before we answer this, what do you think the pathology could be? Is it subdural or epidural? Mm. Subdural, epidural. Someone says epi. Mm-hmm. Mm-hmm. Any other responses? Another person says subdural. Okay, let's see this. Now we say the first thing we look at is the dura, right? And so for this picture, it's a bit it's been removed. Now this is the calvarium has been removed and put on the side of the table, right? So we try to trace the dura. If this is a skull, let's assume this plate is a skull, or let's assume a plate is a skull, right? And I assume food is the brain. And I assume I've put two sheets of paper or a sheet of paper in between the food, or maybe not a sheet of, or maybe a sheet of foil in between the plate and the food, right? Now, the sheet of foil will act as the dura. Let's say now this sheet of foil is firmly adhered to the plate. And I have a bleed. Well, now I can have two types of bleed, right? I can have a bleed in between the foil and the plate, and in between the foil and the food, right? So the bleeding in between the foil and the plate will be the epidural. And the bleeding in between the food and the foil will be subdural. I hope I've not confused. The bleeding between the plate and the foil will be epidural. And the sorry, let me just collect. So the bleeding between the plate and the foil will be epidural. And the bleeding between the food and the foil will be subdural, right? So let's use the same for this. This dura is firmly attached to the periosteum, right? But this bleed is above the dura, right? In this picture. But if I turned it around, it will be below. So it means that this is not between the periosteum and the dura, but it's between the dura and the parenchyma. So which bleed is that? Is it subdural or epidural? So this is subdural, because you look at the layer. Yes, exactly. Subdural, because it's between the dura and the parenchyma, right? It is sitting below the dura. So this bleed is only on specifically one half, but the half that has been affected, there is extensive spread, right? Maybe it's because of maybe the falx. Remember the falx? Maybe the falx cerebri has sort of partitioned this area of the brain, preventing the blood from crossing over. And even when you look at the lower part, the blood was almost sort of crossing over, right? So here you have extensive spread of the blood. And I think the only thing that hindered it from spilling over to the other side is the falx. Ideally, you see there's a large spread, which is very characteristic of subdural. Hope that's clear. Is that okay? We can move to the other question. Awesome. So this kind of explains the same thing that we've been trying to explain. How can you see the pia and the arachnoid? So usually the arachnoid layer is a potential space. It's a web-like potential space in between the dura and the pia. Now the pia is this sort of colorless membrane adhering to the parenchyma very tightly, like very small, barely see it, sort of invisible, but it's adhering directly to the parenchyma. And that's why we say for subarachnoid, you can't wash it off because it's below the pia. That's why you can't wash it off. But for the subdural, you can easily wash it off. Okay. So that diagram that has been shown there simply explains these spreads. You can see on the red side, you have a epidural. The sutures have bound its spread, and therefore it is confined to one area. But the subdural is sort of the blue side is spreading towards a larger area without any confinement. Now let's move to the picture below and try answer it. What do you think this pathology could be? We trace the dura and determine if it's seated below or above the dura. Exactly. You guys are doing well. So the dura is that kind of envelope appearing structure, that grayish structure there. And below it is the hematoma. And so this would be the subdural hematoma. Great, guys. And then below that, the image below, we have this extensive spread, which is not bound by the suture or the adherence of the dura on the suture. So this is characteristic of which type of hematoma, where there is extensive spread? Subdural, exactly. So I hope now you see how you can easily differentiate those two, right? Look at the dura. If dura is too confusing, kind of try and compare the spread and see relatively how much it is. Okay, the next one, we see if we've grasped it. Okay, now which one is this? Is it epi or sub? Epi, exactly. And why is it epi? Trace the dura. Now in this picture, it looks whitish, right? So this is seated on top of this whitish or grayish envelope-like material up on top of it. So that is epidural. So seated on top of the dura, and the area of spread is not that extensive, just a small area of spread, maybe because of the bound suture lines. Exactly. Exactly. You guys are doing well. Okay, we move to another one, the one below. I hope now epi and subdural is a bit more clear. Yeah. Now we move to a new one. So what do you think this pathology could be? Someone says subdural. Any other responses? Subarachnoid. Subarachnoid. Yes. So this is subarachnoid, right? So this one, you can see that the blood is not on top of this layer, right? The layer that you expect to be here on top is the dura, right? We expect to see the covering of the dura. And this hematoma or this hemorrhage is not on top here. It is sort of below. It's like confined in between the brain and something else, right? You can see if I try to pour water here, this hematoma will probably not wash off. That means that this hematoma is probably behind another layer. There's another layer protecting this hematoma from washing off. And this other layer, which is almost transparent, is what we call the pia mater. Someone asked. So below this pia mater, there is the parenchyma. And in between the pia mater and the parenchyma, there is a hematoma or there's a hemorrhage. This hemorrhage is what we call the subarachnoid hemorrhage. And we said last time, what causes subarachnoid hemorrhages? Yes, the most common cause is the rupture of berry aneurysms or circular aneurysms. And you said they present with thunderclap headache. That is that is thunderclap headache. Worst headache of my life. Okay, great. So below there we see a picture of the circle of Willis. I think is that well understood? Yeah. So below here we have a picture of the circle of Willis. This just basically tries to show where most berry aneurysms are found. So about 95-96% of berry aneurysms are found toward the anterior end of the circle of Willis, specifically between the anterior communicating and the anterior cerebral and the medial cerebral arteries. Yeah, so that's why you find most circular berry aneurysms. So there's a question: is the subarachnoid between parenchyma and pia, or between pia and dura mater? So it is between subarachnoid, so it is between parenchyma and the pia. That is subarachnoid hemorrhage. Parenchyma and pia. It is confined by the pia mater. The one you're saying between the dura. Oh, I see why you will say it is between the pia and the dura mater. Because how these layers are arranged is subdural, is the dura, arachnoid, and pia. But the one which is between, ideally speaking, the one we said a subarachnoid area or subarachnoid layer or arachnoid layer, layer for that matter is a potential space. So from what we said, the epidural is between the periosteum and the dura, and the one which is below the dura is subdural. So ideally speaking, the one which is in the subarachnoid space is the subdural, right? And the one below it now is this subarachnoid. Subarachnoid means below the arachnoid, right? So it is not inside the arachnoid, it is below the arachnoid. And which layer is below the arachnoid? That is the pia. So that's why we say that this subarachnoid hemorrhage is below the arachnoid, and that's the pia. So it will be between the pia and the brain parenchyma. That is subarachnoid hemorrhage. I hope that sort of clarifies a little bit that, so don't get confused by the word arachnoid. Maybe look at the sub below. Good, good. Sawa sawa. So there's a picture here. I'm not really sure if they bring CTs, CT scans or imaging, but this is basically we're trying to show diffuse axonal injury, and it was evidenced by the small multiple hypodense punctuate lesions. And those things that look like worms inside, black worms inside this parenchyma. Those are what we call axonal injuries from contusions. Okay, we move to the next question. Let's not waste time too much on that. Okay, here we have an interesting pathology. Yeah, we have sections of the brain. And then we have a histology cassette on the bottom right with a few things inside. Now, what do we think could be the pathology that is being displayed here? What could be the pathology? Any tries? Maybe a hint. Let's try look at the brain section at the top right. There's something about that section that is not quite right. What could it be? So maybe I can help. When you look at the section on the top right specifically, there's a place that looks like it's darkish, right? And this place that looks like it's black, sort of black, where you expect to see the base of ganglia. That area looks black. And is that normal? Is that black appearance normal? No. So what do you expect from this? What could be the underlying pathology? There's some ischemia, probably some necrosis as well, right? And so what pathology could lead to ischemia or necrosis? So that would be most probably an ischemic stroke. Right? So that pathology could be very easy to miss, especially under pressure. It's limited time, but I think that helps. That top right segment, where there's that black portion, leads you to suspect there is ischemic stroke. Now, what could be the cause of this ischemic stroke? You can have multiple causes, right? Have embolism. So someone